Good morning, everyone. Myself, Dr. Mounika, currently doing my cornea fellowship in cornea refractive services in Shankar Eye Hospital, Guntur. Today, we shall be discussing about presentation of sterile infiltrate post refractive surgery. Before we dive into the case, let's discuss few basics. Peripheral cornea is predisposed to inflammatory reactions due to its rich vascular and lymphatic supply to the limbus, and also due to the presence of antigen presenting cells. Peripheral corneal infiltrates can occur due to different pathologies. It includes presence because of staphylococcal toxins from the eyelids or ulcers associated with autoimmune or collagen vascular diseases. So PRK is a common surgical procedure for the treatment of mild to moderate refractive error. Its rare complications include infectious and sterile keratitis. So based on review of literature, the pathogenesis of this entity remains unclear. However, few postulated theories are usage of topical NSAIDs or teophyllum antigen hypothesis. So what is this teophyllum antigen hypothesis? Usually, pooling of the teophyllum occurs at heaped up epithelium and also under the bandage contact lens. So at this area, staphylococcal antigen deposition occurs, which results in enhanced cell-mediated immunity causing infiltrates. The other theory was usage of NSAIDs. NSAIDs inhibit cyclooxygenase pathway for the metabolism of arachidonic acid. This inhibition causes increased production of leukotrienes from the alternate pathway, which is mediated by lipoxygenase. So these chemoattractants result in deposition of inflammatory cells causing infiltrate. So with this basic knowledge, let's discuss about our case. A 24-year-old male patient presented to our clinic with chief complaints of redness and watering in left eye since 2 days. There was no history of itching, pain or diminution of vision, and there was no history of ocular trauma or head injury. He have undergone PRK in both eyes 5 days ago for compound myopic astigmatism, and he was using topical steroids and antibiotics postoperatively. On examination at 5 days post-op, his uncorrected and best corrected visual acuity was 6.6 and 6 in both eyes. And on slit lamp examination, right eye was normal with BCL in situ, but in left eye there were dense lid crust on lid margin. There was mild conjunctival congestion, anterior chamber was quiet, and we have noted a presence of arc-shaped or half-moon shaped creamy white infiltrate in the paralimbal area of approximately 4 into 2 millimeters, with intervening clear zone between the cornea and the infiltrate and the limbus. So rest of the findings were within normal limits. So we made a diagnosis of both eyes status post PRK with BCL in situ, and we considered left eye differentials of infiltrate, debris or scar. So as it was present even after removing the BCL, we have ruled out debris, and as we can see the cellularity in the slit section, we have ruled out scar. So it is either infectious or sterile infiltrate. So corneal scrapings and cultures along with the BCL were sent, and we started the patient on fortified vancomycin and Oflox D eye drops hourly. We have explained the patient about importance of lid hygiene and also explained about lid scrubs. We asked the patient to review after 5 days. At 5 days, infiltrate was noted resolving along with the scarring in left eye. Corneal scrapings and cultures were turned out to be negative, but however, as it was responding, we have tapered Oflox D and fortified vancomycin eye drops, and we have continued the lubricants postoperatively. At 3 weeks, we have noted complete resolution in left eye as shown in the picture. So to discuss, sterile corneal infiltrate is rare after refractive surgery. The most likely cause of paralimbal sterile corneal infiltrates in this case was suspected to be antigens contained in the pooled teophyllum under the bandage contact lens. So differentiating between infection and inflammation is difficult as infiltrates can occur with both the conditions. To conclude, infiltrate after refractive surgery is a potentially vision threatening complication. It highlights the need for a proper schedule of follow-up. Sterile infiltrates with sudden onset can be successfully treated with aggressive steroid therapy to avoid significant corneal scarring. Treatment is usually successful with excellent prognosis. These were my references, and